Hi, my name is Hyun from Korea University Ansan Hospital, and it's my honor and a great privilege to be given an opportunity to interview Dr. Reddy, who is a world-renowned gastroenterologist. To briefly introduce Dr. Reddy, he is currently the chairman of the Asian Institute of Gastroenterology at Hyderabad, which, as far as I know, is the biggest gastroenterology hospital in the world. And he has served as the president of World Endoscopy Organization from 2014 to 2017, during which the first World Congress of GI Endoscopy was held in Hyderabad. And among many accolades and awards he has received during his career, I would like to mention that he was given the Master Endoscopy Award by the American Society of Gastrointestinal Endoscopy in 2009. And this award is regarded as the Nobel Prize of Endoscopy. And he was also awarded the Padma Bhushan in 2016, which is a very prestigious award given by the President of India. So it's my great pleasure to introduce Dr. Reddy to you. And Dr. Reddy, thank you very much for taking time out of your busy schedule to join us for this interview during APDW 2018. So the first question I would like to ask is, during the PG course in the morning today, you gave a lecture on acute severe pancreatitis, initial management, indications, timing, and therapeutic modalities for drainage. So could you give us a brief summary of your lecture and tell us the most essential point of your lecture?
Thank you very much for this invitation. This morning I gave a talk on acute pancreatitis, the consequences, and what endoscopy's role is. I briefly talked on gallstone pancreatitis, but my main focus of talk was on peripancreatic fluid collections which can occur following acute pancreatitis, either in form of pseudocysts or walled-off pancreatic necrosis. I summarized that in pseudocysts, there's no need of any treatment, but for patients with walled-off pancreatic necrosis which are symptomatic, especially if they have infection, they produce gastric or biliary outlet obstruction or organ failure, these patients, the walled-off necrosis has to be drained. And I suggested that from the literature evidence that's available, it looks like that metal stents are better than plastic stents. But we have to be careful because metal stents can have some complications like bleeding, and one has to choose these patients very carefully. I also suggested that these stents should be removed by 3 to 4 weeks. If they're kept longer, complications can occur. And if the patient has a disrupted pancreatic duct syndrome, then in those cases, in addition to the metal stent, we must keep a plastic stent at least after 4 weeks so that pancreatic fistulas will drain through the stomach. So this was the main message of my talk.
So another topic of your lecture during APDW 2018 is about endoscopic treatment of painful chronic pancreatitis due to stricture and stone. So could you give us a brief snapshot of your talk?
Pain is one of the common manifestations that patients with chronic pancreatitis come to the gastroenterologist, in addition to diabetes and sometimes malabsorption syndrome. But the type of pancreatitis we see in Asia-Pacific region, called so-called tropical or genetic pancreatitis, pain is a predominant factor. And many of these patients, the pain is because of strictures or stones. Earlier on, these patients were treated with open surgery, but increasingly now endoscopic therapy is being used in these patients. Pain is a complex phenomenon in these patients. There are a variety of causes, but if we relieve the obstruction, that is remove the stones or remove the stricture, then pain can be relieved. And endoscopically, we can do this. Now for stones, especially stones in the head region with obstruction to the duct, we do extracorporeal shock lithotripsy, breaking the stones into small fragments and clearing the duct. For strictures, we can put stents, and I think from Korea we have large experience to suggest that completely covered self-expanding stents are useful in these patients to relieve the obstruction. In both of these situations, this type of therapy competes with surgery with equal efficacy. We now have long-term results in our unit for about 3,000 patients followed for up to 10 years, and we have shown that 80% remain pain-free after endoscopic therapy. So to summarize, patients with chronic calcific pancreatitis in whom there are stones in the head region or a stricture in the head region can be treated endoscopically successfully. It's important that in these patients, alcohol and smoking must be stopped. Otherwise, they continue to have pain. But endoscopic therapy can be very effective in this group of patients on long-term basis.
Chronic pancreatitis who develop pain due to obstructed pancreatic duct stones. These patients usually require as well or extracorporeal shockwave lithotripsy to fragment the stones and remove them endoscopically. But it seems like the power and the number of shock waves needed to fragment the pancreatic duct stones, they're somewhat different from the power and the number of shock waves used to break down the renal stones or urethral stones. Could you comment on how best to use the Aswell to break down the pancreatic duct stone?
So this is a very important question. Renal stones differ markedly from pancreatic stones. Renal stones are very easy to break down and fragment, whereas pancreatic stones, there are several difficulties. Number one is to localize the stones by ultrasound is difficult, so we always use fluoroscopy to localize, so they have to be radiopaque. And second is pancreas is very deep retroperitoneal, and therefore to target these stones is not so easy. Third thing, with respirations as the stones are moving, it may be difficult to target these stones. So pancreatic stones require a different approach. The first approach is in these patients, for extracorporeal shockwave, we use a large amount of shockwaves, at least 3 to 4 times of what we use for renal stones. That is number one. Number two, we always target it under fluoroscopic control, not ultrasound control. The third most important thing we have found is that if we use epidural anesthesia, not sedation like you do for renal stones. In this case, we must use epidural anesthesia. If you use an epidural anesthesia, then the response is very good because the patient's respiration is controlled and we can then target the stones very well. The fourth important thing is that we have found that all machines are not useful. There are only certain specific high-end machines, third generation machines from different companies, which can be used to target the stones because the energy delivered has to be very specific and has to be of high level. So taking these 4 things into consideration, we now have operator. It's also operator sensitive. We must have the same operator doing this rather than different operators. So if we do this, the principle is to break down the stones into less than 3 millimeters in diameter. And if you can do that, you can clear the pancreatic duct with the high success rates. So if we use the right technique, in about 85% of the cases, the stones can be completely fragmented. And in 70%, we can clear the duct completely.
I have many questions I want to ask you, but due to time constraints, I would like to ask you one more question. It's more of a request for advice than a question. You have been, you still are, and you will always be, I believe, a role model to many endoscopists. And as the master of endoscopy, what kind of advice would you give to the younger generation of endoscopists who look up to you and who would like to follow your footsteps?
The advice that I'd like to give is that whoever wants to take up endoscopy should be genuinely passionate about it. They must enjoy doing the procedure. There are, of course, some people who want to do endoscopy for other reasons. I think in that case, one should not take up endoscopy. Endoscopy should, for those who are truly passionate about it, enjoy doing the procedures. The second important message is that when you take up endoscopy, you have to work very hard on it. It is not something that comes very easily. It requires hours of practice to become very good at a certain area. The third thing is to take a role model in your own institution and to follow him. I think it's very important to have a master for endoscopy. So you must have a guru, as in Indian language you call it. If you must have a guru whom you follow, who will teach you all the nonsense of endoscopic techniques. And of course, it's also very important to sub-specialize into one area. Endoscopy is very broad. Initially, when we started endoscopy, we were doing everything, colonoscopies, endoscopic ultrasound. Now it's become very, very specialized. So if you want to be truly world-class, you must sub-specialize into either, say, pancreaticobiliary endoscopy or a small bowel endoscopy or colonoscopy and so on. This sub-specialization is becoming very important. So passion, hard work, sub-specialization, and select a good guru. These are the mantra.
Thank you very much for your precious advice. And thank you very much, Dr. Reddy, for sparing your precious time for this interview. And I believe that your advice to the junior endoscopists will help them greatly shape their future as gastroenterologists. Thank you once again for coming, and we will be anticipating more of your great works in the future. Thank you.
Thank you.